I am very pleased to introduce Dr. Jeanne Gallée. She's a researcher at UW Department of Medicine's Center for Psychometric Analyses of Aging and Neurodegeneration. She's also a research education component trainee at the Alzheimer's Disease Research Center and a licensed speech language pathologist practicing in the greater Seattle area. She's an adjunct instructor at the Massachusetts General Hospital Institute of Health Professions and affiliate faculty at Emerson College in their respective departments of communication sciences and disorders. In 2021, she completed her PhD at Harvard University in the program of Speech and Hearing Bioscience and Technology with a focus on characterizing heterogeneity in language profiles in primary progressive aphasia, a rare clinical syndrome due to dementia that results in primary impairments to speech and language. So I think you can see she has tremendous expertise to share with us on speech therapy and dementia care. Welcome, Dr. Gallée.
Thank you so much for that introduction. I'm truly delighted to be a part of the Dementia lecture series, and particularly to be able to speak on speech therapy and dementia care. So if I have any primary message that I do hope to convey in today's presentation, it is the importance of identifying change to speech, language, and communication on the spectrum of dementia, and then, of course, using that information to make appropriate referrals in our care for this population. All right, so here is a broad overview of everything I hope to cover in today's presentation. It seems like a lot. It probably is, but I do think we'll get through it all. So I'll begin with disclosures, then defining the scope of the speech language pathologist. You'll see that I refer to the speech language pathologist as the SLP on this page. I will begin with defining swallow function and the SLP's role here, and then move on to defining constituents of speech, language, and communication. What do these actually look like in a real-life interaction with a person? Then I'll cover clinical syndromes that impact communication, and then how we can determine the need for referral to SLP services. Then I'll do a broad overview of therapeutic approaches used in speech-language therapy. And then finally, I'll wrap up with communication modifications for providers. All right, so my own disclosures beyond the land acknowledgement is that my focus is cognitive linguistic, just based on the virtue of my own training and professional experiences, both as a clinician and in my work, which is why I will begin with that definition of swallow function to make sure I give it due credit. And then for those of you who had a chance to look at the slides before, you'll know that there are many images used in this presentation, and most of them are drawn from Participics, which are generated and made available by the Aphasia Institute. All right, so let us get straight to it. What is the role of the SLP across populations? It can be broken down into 4 broad domains. We can think about assessment, intervention, counseling, and advocacy. So what do we do in assessment? In assessment, it is the SLP's primary aim to capture and track behavior in domains of swallowing, speech, language, and communication. We also want to evaluate aspects of cognition to characterize its role in these capability areas. So we might use screening intervention tools or assessments to then figure out if there are other factors that are impacting someone's performance. We also work on intervention. So we use those outcomes from our careful assessment to curate and implement therapeutic intervention. Intervention can broadly be broken down into 3 approaches. The most common one that we all associate with intervention is restitutive. So here we're thinking about improving or maintaining functions that have undergone change. So if we are concerned about naming, we will think about a restitutive intervention that actually restores or helps us maintain access to naming. We also think about compensatory approaches, and these are ideally implemented for every single patient that we may see. So here in a compensatory approach, we hope to augment or compensate for those lost functions by introducing strategies that can help. So instead of improving the actual domain that's impacted, we think about accessing or introducing other approaches to help someone be more functional. And then finally, and perhaps most relevant to our patient population on the dementia spectrum, we have a palliative approach. And here we think about adapting our approach continuously in light of the change and its continuous insidious impact. So in this approach, we often implement many more aspects of advocating for patient autonomy, success, and also integrating them into a really well-defined and interdisciplinary healthcare team. The next part is counseling. So not to be confused with any other aspect of counseling that is outside of our scope, we provide informational counseling as it relates to a diagnosis and its implications for the patient, care partners, family, and community. And then finally, we provide support. So in particular, as speech-language pathologists, we are experts of communication. And as it turns out, communication impacts most interactions we have in this world, whether it's filling out an online form, speaking to a loved one, or picking up a prescription. Communication change can impact all of those types of interaction with the world around us. And that can, of course, then have a really terrible effect on someone's life participation and overall well-being. So here, SLPs advocate for and promote patient autonomy across professions and within communities. So a common community tool that I'll talk about more later is an aphasia identity card, a simple tool that someone can keep in their pocket or their wallet to communicate with the rest of the world that something about their communication has changed. And then finally, in our role as supporters of these clients and patients, we connect patients and families with others facing the same or similar conditions. So what I hope to convince you all of is that the speech-language pathologist can play a role at the time of dementia diagnosis, even prior to that, and then across that continuum of care as their condition progresses. So I've spoken to the domains upon which the speech-language pathologist can work towards, but what is our actual scope? What do we do with a patient with dementia or suspected dementia? I hope this image shows our broad overview. I like to say we work on everything from the hip bones up, thinking about the musculature in our diaphragm, our lungs, our abdominals, all the way up to the brain. So we work on general cognition, speech, language, and breath support. And of course, swallow function. Before I forget, I do want to say that swallow function isn't something that I personally, nor my colleagues, think about immediately for the average dementia patient until the later stages of a condition. So unless this person is facing a diagnosis that primarily impacts motor components, which may be related to a weakness, so a dysarthria, or a general motor planning disturbance, we don't think about swallowing until the later stages. Okay, but what do we look for when it does come to swallow function? We really recommend a referral to speech-language pathology if we see insufficient lip closure or drooling. That just tells us that something about the overall control at rest or while drinking or while eating is different. Something is atypical. Beyond drooling, we think about the time it takes to actually consume any type of substance, whether it is a liquid, a solid, something in between. If someone is taking a really atypical amount of time to actually form what we call a bolus, or a condensed amount that someone can swallow, that also tells us that something about the coordination isn't quite right and could pose a safety hazard. We also are concerned about insufficient clearance following swallowing. So if someone swallows and then you see lots of residue inside of the mouth or around the mouth, that also tells us that there's either insufficient strength or coordination going on here. And that all ties back to the fact that swallowing is one of those wonderful functions like breathing, where until something goes wrong, we don't think about it too much. It just tends to happen as we need it to, and it's a very natural response. And so when things aren't going quite right, that's when we really need to be concerned. We are also worried about coughing while eating or drinking. That tells us that when the food or the liquid being consumed is traversing down, it is accidentally making it onto the level of the vocal folds rather than into the laryngeal space where we want it to. So that, of course, can lead to pneumonia. If food actually or liquid makes it into the lungs, that can lead to an infection. And of course, we always want to avoid that. Something that people commonly talk about is a wet sounding voice following swallowing. This has been a little bit debated in the literature, but it is still good to look out for. If someone sounds like they just have something on their vocal folds after swallowing, that could be an indication that food is not making it to where it needs to efficiently. Based on everything I just said, of course, repeated chest infections are of concern as well. That is also an indication that something about the swallow process is not working quite as it should. Significant and unexplained weight loss, so not explained by the absence or forgetting to eat, that is also a sign of concern. And discomfort at the proposition of eating or drinking. So especially for our patients who are at the more moderate to severe stages of dementia, if they aren't explaining but showing that eating or drinking isn't of comfort to them, and that's a change from before, then that is a red flag and an indication for referral. So what do we do to assess once the person has been referred to us? We try to visualize what is actually happening at the level of swallowing. And this can be done in two major ways. Beyond a bedside evaluation, we can visualize an actual swallow process through an endoscopic assessment. So here we are looking at the way the larynx is moving in response to the introduction of food or liquid, or even just plain saliva, by inserting a camera up the nose and into the larynx. And that allows us to see what is happening exactly at that level. A more intensive approach is a modified barium swallow. And this is where we actually are looking at food or liquid that has been not contaminated, that has been labeled with a barium trace so that we can use an X-ray to actually image what's occurring at the swallow. So this gives us a lot more information. It's a lot more intensive on the part of the patient. Of course, it's more invasive just by the virtue of the type of assessment, but this is really the most detailed evaluation that we can give to then make recommendations for how someone should be consuming their food or which foods or liquids they are safe to try. So in terms of therapeutic approaches, we have ones that are restitutive and we have compensatory ones as well as palliative. The most restitutive is exercises to build strength and coordination. So here we're targeting those muscles and those movements that may have been impacted before. A more compensatory approach would be to modify the alignment of the head, body, or overall positioning. So some of you may be familiar with the head or chin tuck, where we ask someone to tuck their chin prior to initiating the swallow of the bolus that they have formed in their mouth. Again, this may or may not work for every patient. It depends on their anatomy as well as their success in performing this procedure. And it should be informed by the SLP and not just based on the fact that this exists as an option. We also have different types of alignments. So some people benefit from turning their head to one side and angling downwards. Again, this depends on the individual patient. And then we also have modifications where we don't expect the patient to initiate any of the changes, but instead we provide them different types of things to consume. So we may choose a more viscous liquid diet. We may choose solids only. It all depends on what the underlying nature of the swallowing concerns is. All right, so with that overview of swallow function, I'm going to transition to defining communication. What am I even talking about when I do refer to speech, language, and communication? Broadly, when I speak to speech, I am speaking to speech planning and production. So planning is the side where it really just happens at the level of the neuron, where all of the information about how to say something is being sent and programmed into the associated musculature. Whereas production is really at the level of what I'm doing right now, or what you're seeing me do, and that is producing that verbal expression. We think about language in terms of retrieving information, producing it correctly, and then understanding it. So when someone is speaking to us or writing something for us, what are we taking away from it? We also think about social pragmatic conventions. There are people on the dementia spectrum who don't have any difficulty with speech or language, but it's how they use their speech and language that makes them stick out and also have indicators for referral to speech-language pathology. And then finally, as I touched upon before, elements of cognition are also really important for us to consider, particularly when it comes to memory or attention or overall behavior, and how that may play a role in impacting someone's overall communication. Okay, so I am sure all of you are highly familiar with this symbol of the umbrella of dementias that exists. So I specifically want to speak to the clinical syndromes that do result in communication change. We have syndromes where changes to speech, communication, and language are the initial symptoms of this actual syndrome. So that can include ALS, when it's a bulbar onset. It includes the primary progressive aphasias, and it includes the primary progressive apraxia of speech. Importantly, while we have this collection of primary progressive aphasias that fit into one nice and neat clinical syndrome, we also have that differentiation of disease etiology. So the non-fluent and semantic fit in nicely into the frontotemporal dementias, whereas the logopenic tends to be attributed to Alzheimer's disease. That's why you also may see more overlap between typical Alzheimer's disease and the logopenic variant. The distinguishing factor being that the primary progressive aphasias tend to be early onset, so where symptoms arise or are noticed before the age of 65. We also have plenty of syndromes where speech, language, and communication difficulties arise as the diseases progress. So again, that includes ALS. For some individuals, they may initially notice limb weakness in other extremities, and then over time experience difficulty with breath support, meaning they have reduced voice and intelligibility, or in their actual articulators, where understanding what someone is saying becomes quite difficult due to the lack of precision. We have typical Alzheimer's disease, the classic dementia syndrome, if you will, at least in pop culture. Other atypical dementias, such as posterior cortical atrophy, where initial symptoms are restricted to visual spatial functioning, but then can progress to other areas. Cortical basal syndrome, dementia with Lewy bodies, behavioral variant frontotemporal dementia, this one being a classic example of no challenges in speech and language initially arising, but we have those social pragmatic differences that can have really invasive impact on everyday life. We also have Huntington's disease, Parkinson's disease, and progressive supranuclear palsy. All right, so in this discussion, I just wanted to present some cases with non-classical aphasia or language-led syndromes, just to highlight how these areas of speech, language, and communication can be impacted in these syndromes. So for our first case, We have a 72-year-old patient with a diagnosis of Parkinson's disease who himself raises concerns over the fluctuating control he has over his speech. So for his speech, he says that his loudness is impacted. He isn't heard as easily. And then in addition to that, the control he has over the precision of what he says, like those speech sounds in particular, often results in communication breakdowns. And so he's frustrated because that leads to family and colleagues often asking him to repeat himself, which of course only exacerbates the issue. In terms of language, he reports that there are no changes to comprehension, naming, or grammar, and that is consistent with SLP assessment. And then because of those changes to speech, we actually see a cascading impact to communication. So typical social behaviors that rely upon that clear and ease of communication actually result in this patient withdrawing from many of these interactions. It's too cumbersome, it's frustrating, and then that, of course, has a huge impact on his career as well as in his family life and social network. For our second case, we have a female patient who has been diagnosed with the behavioral variant frontotemporal dementia. Here, it's not necessarily the patient that themselves that is voicing concerns, but more so her significant other. So in terms of speech, at this stage, no changes to articulation, fluency, or breath support are reported or noted. Similarly, for language, we aren't seeing any observable substantial change, but we are seeing it in communication. And while the discussion is led by the significant other, the patient is receptive and is open to hearing that, I'm not initiating communication like I used to. I seem kind of apathetic in our daily conversations. I'm not processing what my husband is telling me in these situations. I'm not understanding the intonational patterns that indicate frustration or agreement or excitement or even sarcasm. And I'm also hearing that maybe I'm not expressing my emotions. So it's not just that there was a difference in emotion processing, but that communication of emotions is different. And then finally, we have our more classic aphasia syndrome of logopenic variant primary progressive aphasia. And here we see the whole gambit of challenges across speech, language, and communication. So the ways in which we may approach these reported changes will be addressed later on in the slides, but here I hope to have shown a potpourri of the different ways in which these three domains can be impacted by different types of clinical syndromes of dementia. All right, so I threw a lot of jargon at you in talking about speech, language, and communication, but how can we actually look at features of each of these to define them? So let's begin with speech. We can consider speech the packaging of communication. What does it sound like? How easy is it to understand someone? How comfortable is it to listen to someone speak, even? And we can break that down into articulation, fluency, and breath support. So what is articulation? Articulation is the coordination and regularity of articulatory movements. So how precise am I? Am I making speech sound errors? Or does everything sound exactly as it should? And it can also refer to that phonological short-term memory. That's jargon for someone's ability to repeat back to you what you've said to them. Can they hold on to those articulatory sounds and repeat them back? The next part is fluency. So here we think about prosody, intonational patterns, how smooth someone's speech is, how appropriate it sounds. And what's interesting is that while there are really objective measures of fluency, it's very easy for an untrained listener to say, that sounds as expected, and that does not. And so a classic atypical example is when someone has lots of pauses, lots of atypical pauses, if they're prolonging parts of words and then changing how quickly they're speaking. So really thinking about the order and the procession of speech here. And then finally, we think about breath support. So that final element of packaging is how well is someone able to use their breath to support their speech? Do they sound really breathy? Do they need to inhale again and again to support the actual verbal expression? Or are they able to show compensatory strategies in the face of musculature decline? So what do you need to look for to even see an indication of change? For articulation, we're looking at the accuracy, how well you understand someone, and also perceived effort. Does it look like someone's really forcing to get the sounds out, or does it seem relatively easy? For fluency, we're looking at that perceived naturalist and melodic line of speech. Does it sound normal? Using that word normal with caution, but does it sound as you'd expect based on a person's cultural background, age, and education? And then finally, breath support. Does this person sound strong? Do they have the adequate strength to support their verbal expression? And we can think about that in terms of how loudly someone speaks and how many breaths are needed to communicate. All right, so we've talked about speech. Let's think about language. Language can, again, be broken down into multiple domains. So let's start off with expression. We think about language being the content of speech. What is someone saying versus how do they say it? And so in expressive language, we think about naming and grammar. So what is naming? The ability to retrieve names, concepts, actions, pronouns, anything that requires labeling. So naming can be very interesting because some people are more specific than others. This again depends on background, education, profession. What does someone do every day? Does someone love New York Times crossword puzzles? Do they love pop culture? What is it that they are using to stimulate themselves and to communicate? But there are specific tests to assess naming that are standardized to the one-size-fits-all approach to look at what is definitely a concern in ability. And then we think about grammar. Thinking back to what we learned in elementary school, what are the rules that govern our language? What word orders are allowed? Which ones are acceptable? We can think about high complexity, low complexity, and overall accuracy. So when we look at naming, we want to look at the use of appropriately specified words in conversation. So again, there is no gold standard of what is specific enough or accurate enough, but we want to look at what's appropriate. If someone is saying, I don't know, that thing over there that touches that thing with a thing, that should be a red flag, particularly if the person themselves or their care partners are saying that's different from before. When it comes to grammar, a lot of people get away with really accurate but very short statements. So what we want to look for again is that change. Is someone cutting off their sentences or using phrases that seem different from before? Are they really simple? And this is something that also that care partner report can really help with. If you're seeing change in accuracy, where we're seeing certain function words being totally dropped, someone is only using nouns, saying cat, table, food, instead of saying the cat is jumping on the table to get the food, that is also an indication that there has been a change in someone's grammatic ability. The flip side of language is the receptive part. What does someone...
Can I just
Yes,
interrupt for a
absolutely.
minute? I just wanted to mention that Mary Zeitner had mentioned some time ago she had a patient with dementia. Can't recall if it was frontotemporal or Lewy body, but her speech was interesting with the normal cadence and intonation, but it was more of a word salad.
Yes, that can also occur. And that really speaks to that language component. What is someone saying? And that we can see in certain clinical syndromes of dementia as well, that someone sounds fine, where if you were only half listening or maybe a non-native speaker or didn't speak the language that this person was speaking, you may not notice or appreciate some of those content-based changes. And so there are conditions that result in what we call pressive speech, where someone is speaking and speaking and speaking and speaking, or the content just isn't making sense.
Thank you. Thanks.
Of course. So interestingly enough, that was actually really nice for the transition. For people who have difficulty in understanding others, we do see more occurrences of word salad-like events. And that makes sense. If you aren't understanding others, you probably aren't processing what you're saying either. And then we see those atypical patterns. So when we think about the receptive side of language, we think about comprehension. And that can range from understanding single words to understanding written paragraphs to understanding a TED Talk. People may experience challenges at those different levels equally or selectively. Most likely, you are going to see people have relatively intact comprehension of high frequency, typical words that we use in everyday conversation, of typical phrases such as no ifs, ands, or buts, even if they're slightly obscure, because that's what's used on a regular basis. And where you might see the breakdown occur over time is when phrases become longer. It's more information to hold on to, and it's more information to relate to one another. So thinking back to those aspects of grammar, the more clauses we have in a statement, the more pronouns, the more concepts we're referring to, the more there is to put together to understand a message. So at the very basic level, you want to see if your patient is a reliable reporter. Do they have reliable responses to yes, no questions, where it's very helpful if you know the answer to some of these in advance. And if you're getting someone saying no to everything, that's where you know that the answer should be yes in other instances. That's a very good indication that this person is not a reliable reporter and that a different approach will be needed here to appropriately address the care that they need. We also want to look at appropriate or expected responses to picture-based, verbal, or written prompts. So if you show someone a picture and ask them what it is, if they go off on a completely different tangent or start speaking about something else, that's also an indication that language is not functioning as it used to. And then finally, what we do see at the later stages is confusion about meaning of more common concepts or references that were once familiar. And that isn't always a memory-related difficulty, but it really can be isolated to aspects of language. You can identify this by seeing if the visual representation of an object allows for a person to show how to use it properly, if it's a tool, or to interact with it as expected, but then hearing the actual name of it or seeing the written word doesn't elicit that same response. All right, moving on from speech and language, we can then talk about social pragmatics. So this is really the performance of communication, taking how someone says something, what they say, and putting it together into the performance of how they use it in interaction. And we can break this down into functional communication ability, as well as social pragmatic functioning. So what is functional communication? In short, how successful are you at communicating what you intend to say? And that can be multimodal. In fact, it should be usually. Even I right now, though I'm on the screen, I'm using my hands to gesture things, whether or not that may be visible. We don't depend only on verbal expression across the spectrum of our population, right? So every person uses some form of multimodal communication. Everyone has word finding difficulties. I might say, I've got the in my hand, and you'll know what I'm saying. I'm holding a mug in my hand, and that was clear because I showed you the visual representation. Functional communication can be highly multimodal. It might involve technology. It might not involve technology. It really is just defined as how successful someone is at transmitting an intended message. Social pragmatic functioning, on the other end, is the understanding of the conventions that govern our society. So this looks different per society, of course. In some societies, eye contact is highly recommended or typical. In others, that's actually confrontational. So it always needs to be interpreted within the context of the society a person operates in. Really simple forms can be, what do you typically say in the United States when you meet someone? You say, hello, how are you? Whereas in other countries, that may not be typical. But if someone used to always say that, and then all of a sudden walks into a room, doesn't say hello, does not acknowledge anyone, then that would be a significant change in their interaction and their social pragmatic performance. So when it comes to identifying change in functional communication, we want to see how successful someone is and how independent they are in communicating a message. Do they have long pauses in communication, but then reinitiate when they get a cue from a care partner or even from you as the provider? That can also tell us how open they are or what their potential is for therapeutic intervention. For social pragmatic functioning, we really want to put aside our own biases of how someone should be and actually think about, typically, how is someone in this type of an interaction with me, with or without a diagnosis of dementia? And that can help us think about, is the care partner reporting that someone used to be really kind and now is really cold or seemingly apathetic or disinterested in conversation? Or are they aggressive all of a sudden if that wasn't something that they used to be? And so here's just some visualization of the different types of ways in which someone can functionally communicate. Someone can use gesture, pictures, physical objects. Someone can use their phone, depending on someone's comfort with technology. This is rapidly changing, but technology may not always be a good indicator of someone's functional communication. And we all know that from older family members who may still not know how to charge their phones consistently, right? So that may not be an indication of their overall ability to use strategies, but just that that is a medium that isn't helpful for them. All right, and then finally, let's think a little bit more about cognition. Cognition can be thought about as the implementation of all of those other factors of speech, language, and communication. We want to think about perception. How well is someone identifying and processing stimuli in their immediate environment? Do they even see you as the provider when they walk into a room? Do they see the objects in the room? Do they hear or notice all the incoming stimuli that are around them? We want to think about selective intention. So what is a person's focus on you as the provider or their care partner, or what they're supposed to be doing in the context of your session? And then we want to think about sustained attention. So beyond the ability to focus, what is this person's stamina in focusing on a specific task or a conversation? We also want to think about initiation. Is someone participating in a really passive way? Does it take prompting? Does it take significant cueing for someone to initiate anything from themselves rather than just being responsive to cues? Thinking about our case of BVFTD, we may also want to think about inhibition. So instead of the lack of initiation, is someone able to or demonstrate the ability to inhibit certain behaviors? Is someone saying way more than is expected or saying things that are not appropriate given the situation? Do they show embarrassment about it if it is inappropriate? Finally, we want to think about memory, thinking about working memory and long-term memory. In working memory, we want to see how successful someone is in using information that's being thrown at them in the moment. Can they use that information to make appropriate responses or draw certain conclusions? In long-term memory, are we looking at we are looking at a person's ability to retrieve information from the past outside of the context of this current moment. And so, of course, for all of these, you will want to gather your own impressions as well as care partner reports of a person's success in all of these domains. And if there is change, that is also an indication that you can refer to speech language pathology. So, should I refer to speech language pathology? Any noticeable or reported change in communicative success based on any of those domains we just covered warrants a follow-up assessment with an SLP. That does not always mean that someone is the best fit for intervention, but follow-up assessment with an SLP can identify that. And more importantly, what that results in is in intense documentation of the functional impact of someone's clinical syndrome. And that in turn, while it may not lead to a successful agreement to speech language therapy on the patient or care partner's part, it can lead to other changes that are really important in the integrated care of this person. And so I've just included a link here at the bottom about finding providers, because that can also be really challenging. It's easy to say, I should refer to a provider. If you don't know where to find them, it stops there. So the American Speech Language Hearing Association has the Profine tool where you can look by area of specialty and geographic region and find providers that are open to new patients or even just consultation. All right, and all of the features I discussed beforehand play into the life participation approach to aphasia. So I've used the term aphasia a few times. Aphasia defines a change in language or communication ability. We often think about aphasia due to stroke, but we can see elements of aphasia across the dementia spectrum. And these changes to communication can have significant effects on someone's participation in life situations, personal identity, attitudes and feelings, of course, their functional language ability, and then their general language environment. What is someone able to participate in based on the change with and without supports? And an SLP can help establish that and improve someone's quality of life by working on those compensatory, restitutive, and palliative approaches. All right, so we've identified these challenges. We've referred to speech language pathology, but what actually happens after that? So as I've already mentioned a few times, we have those 3 different foci, and all of those can be used to improve someone's communicative experience and success. So for a restitutive approach, our focus is really restoring or maintaining function of specific skills that have changed as a result of the dementia. Our emphasis here is functionality and relevance to the patient. Dementia is progressive regardless of the clinical syndrome. So saying that any type of restitution is appropriate just isn't correct. We want to focus on functional outcomes that will have the biggest bang for our buck. We want to be able to train words that are specific to someone they want to retrieve all the time and have the highest likelihood of showing success in. So the research has shown that we typically don't see generalization to words or scripts or features or descriptions that weren't trained. So it would really not be of benefit to train words that aren't relevant to someone. In a compensatory approach, we are compensating for that lost function with alternative strategies or modes of communication. And here, our emphasis is comfort and ease to the patient. This is really a strategy-based approach. How can we make someone enhance their communication to increase their engagement and motivation as much as possible? So one technique is actually a circumlocution technique, literally talking around a word or a concept. If they can't retrieve it, we don't focus on getting that specific word, but we use gesture. Going back to the mug example, we can use pictures. We use verbal expression by literally talking around something by saying it's black, it has a mug, I drink coffee out of it. and so forth. And that ends up being a technique that needs to be trained. It's not necessarily habitual, but we can create really efficient communicators by introducing circumlocution. We can think about using devices external and within our body. So when I talk within our body, I am talking about my extremities, my hands. If I am talking about drinking, I can indicate drinking with my hand. There are other universal gestures. I can indicate a yes or no response with my face, or even fear. That is all very low tech. And what's amazing about it is that you're always carrying it with you wherever you go. In contrast, we have some really nice high-tech devices, such as tablets, phones, microphones, that require a little bit of extra help. And while they can seem amazing in their infinite possibilities, they can also be really complex. So when it comes to charging a device enough so that you can actually use it every day, when it comes to navigating screens, when it comes to navigating all of the infinite choices within a certain application, that can end up getting really messy. But there are really nice ones. There are text-to-speech functions for people who have difficulty in those motoric aspects of communication. We have picture boards where someone can constantly update which pictures they want to refer to. We have just generally smartphones with pictures on them where someone can pull up an album of concepts, people, actions, or activities they are often wanting to refer to, but are missing the language for. We also have in the middle of that gradient of low to high, we also have external devices that are also low tech, such as a pen and paper or a whiteboard. And what's cool about all of this is that it's not just the patient who can benefit from using these, but the provider. So sometimes when comprehension is a challenge, the provider can then use the whiteboard to draw choices or to show pictures of different objects. They can use a tablet to do something similar. That leads me into communication partner training. And this is for care partners, but also beneficial for providers with a different emphasis. But helping the person with the communication challenge by modifying our own communication patterns and the ways in which we set up the environment in which we want the communication to happen. And then finally, we have the palliative approach. So here we're adapting ourselves to evolving symptoms and expressed needs. That can involve counseling, that can involve involving or changing the interprofessional team, all with the purpose of advocating for the prolongation of patient autonomy, because we all know that is an immediate factor in overall health outcomes and well-being. The emphasis here is creating an interdisciplinary and responsive care team and trajectory of care to enhance the quality of life. Examples of this include connecting the patient, care partners, and families with local support groups and networks, identifying moving targets when it comes to someone's daily activities living, and ways in which to maintain connection, whether that connection is to other people or to their identity and their ability to participate in daily activities of living. So one classic example that I just want to put out here, in addition to that Profine tool, is the aphasia ID card. So this is somewhere in between a compensatory and a palliative tool, where online you can generate this card where someone can put in a little bit of information about their communicative change and then have it with them at all times. Because more often than not, especially when someone's transitioning from the mild to more moderate stages of communication change, they are going to run into a really hairy or prickly situation that ends up having really significant outcomes just administratively and emotionally on a person's life. So to give an example, I've had multiple instances where someone accidentally became a victim of fraud, losing upwards of $50,000 because they were scammed. And it was in a situation that they weren't used to what was happening. It was a phone call. They were caught in a vulnerable situation. And then because of the language change, this could happen. I've also had people accused of being drunk due to motoric change in their language and word finding difficulties, where family members had to actually pick them up from a police station. And all of this goes back to the fact that progressive change, or even just change in communication in adulthood, isn't recognized broadly within our communities. So an aphasia ID card can be super helpful for someone to just have that safety hack to be able to use in those situations that are unexpected, terrifying, and have huge consequences on someone's life. So that can be accessed at aphasiaaid.com. This tool was created by the National Aphasia Association and is free and modifiable for anyone. You can, of course, make your own, but this is a nice way to just get the ball rolling. All right, so I've spoken to the content of speech therapy, the approach, but let's speak a little bit about the structure so that if you do refer one of your patients, you know what kinds of information you can give them about the therapy they may receive. We have typical one-on-one sessions occurring between the patient and the speech language therapist. We have partner-based sessions where the care partner comes in and is an active participant and recipient of the therapy. And then we have group sessions. And these group sessions may be private or community-based, where in the community-based option, it often is free of charge, has nothing to do with health insurance, but is on a volunteer basis from the providers to generate that support network for people experiencing similar challenges. We actually have one of those at the UW Memory and Brain Wellness Center, and it takes place at the Memory Hub. There are different target groups depending on the clinical diagnosis, and it's a really nice way for people to come together in person to learn together, to practice strategies together, but also just to connect. There are also always online options, and I'm happy to speak more to those offline too if someone has any questions about finding those. There are nationally based groups specific to care partners as well as patients where people can join from wherever they are, even from around the world, but they're run through the United States based associations. So one thing that's really important to note is that multiple approaches in that structure and content are often positively indicated. It's generally a good idea to introduce things before someone is too frustrated or too far along in their condition. So here's an example. I might provide a restitutive, compensatory, and palliative approach from the get-go with a person where I provide one-on-one, partner-based, and group sessions where I'm working on specifically improving a communication concern, like naming. I'm also connecting them with a support group where we use alternative and augmentative devices like a tablet or picture cards to communicate and actually not just talk about them, but use them with strangers who hopefully will become connections over time. And then also have partner-based informational counseling sessions where the focus is enhancing communicative success between the partner and the patient outside of our sessions. So really enhancing also the quality of life of the care partner, reducing the burden of being a care partner to promote the overall wellness of the relationship and the health outcomes of the patient. So going back to those cases that we spoke about right at the beginning, for our patient with Parkinson's disease, I may implement a structured program for voice amplification. So this is that person who had difficulties with speech due to that reduced control and strength in their voice. And so what I might do is implement some exercises to actually work on that vocal volume and stamina so that independently they become a stronger and more intelligible communicator. And then I might also introduce a compensatory approach, which involves education and practice of using a microphone, a personal microphone to just help enhance the loudness of this person's voice. For our second case, for our patient with BVFTD, the behavioral variant, I will implement a combination of informational counseling and communication partner training. This is that patient where speech and language seemed relatively fine at this stage, but it's the ways in which this person was communicating that was drastically different from before and harmful on their relationship. So I might introduce joint sessions to learn and practice communication enhancement techniques, teaching both the care partner and the patient objective rules of how we can structure a conversation. I may also have one-on-one sessions for the spouse for more intensive training and informational counseling, providing that guidance without the patient necessarily being part of the discussion on what to expect and how to respond, or ways in which that may work well for this specific situation. And then finally, I may introduce a group support network to connect both the care partner and the patient with the local community. And for our third case, my focus would be a restitutive and compensatory approach to reduce communication breakdowns. This person was still at the relatively mild stage of their condition. So here it's positively indicated to introduce one-on-one naming practice with intensive home practice as well for the patient. So here it really is about what can we regain and what can we maintain for as long as possible. Then we might think about group-based sessions to practice that use of compensatory strategies. So this might be an opportunity for the patient to use and apply some of their home practice, but also to use alternative strategies and just enhance opportunities for functional success. It turns out when you're out in the real world and you're outside of your speech therapy sessions, it isn't that easy to always practice some of these techniques. Families and care partners and friends might try to help a little too much or know you a little too well for you to feel confident to change the way you're communicating. So being in a group where everyone knows that something's a little bit different about your communication because they're experiencing the same things can be really nice to promote the success and use of these strategies. And it just helps a person's confidence. And then finally, one-on-one sessions to directly target a goal that is relatively compensatory, but uses a little bit of negotiation to figure out how to improve communication might be a target. So in this instance, the patient was working as a librarian, and here a goal may be to figure out a way to set up accommodations with their place of work, reduce job responsibilities that tax that verbal expression, but to find a way to keep them integrated in their preferred occupation to maintain that patient autonomy. So I've spoken to everything that we can identify in a patient, what the SLP does with the patient once they're referred. I wanted to end today with some tips for communication modifications for all providers to enhance success in communication. So this is just a visualization of the RAISE assessment framework. And this is all about creating person-centered, individualized assessment. For a person experiencing communication loss, a standard conversation might not reveal their functional success. Someone may be very creative in multimodal communication, but less successful when they're asked to only communicate verbally. And so in this RAISE assessment framework, we think about building the relationship with the patient, whether this is in a 5-minute interaction or a long-term relationship, but just really recognizing them for the person that they are. And then thinking really cleverly about the type of assessment we use to screen for some of these concerns, and maybe even modifying. So filling out the standardized form as it needs to be done, following the directions or instructions for it to be standardized, but then trying out some modifications. Does it help the patient when I draw a picture of the item that is one of the possible options? Can they pick it out of a group of 4? But even if they aren't able to name it themselves. Are they able to gesture the use of something? Can they point to something? Including opportunities for feedback. So if someone is in an assessment or screening scenario, or even just a conversation, and they're having difficulty, create those opportunities for the patient to provide concerns, or to say, that didn't feel like it represents my everyday life or success. And that can go in both ways, whether it means that they do really well on a screener, but feel like that doesn't capture how I'm actually doing or feeling in my everyday participation. Supporting and promoting that advocacy and evolving your approach over time, and especially evolving communication over time. And that is where that power of conversation really comes in. So, general principles: ask simple and direct questions when working with our patients on the dementia spectrum. It turns out the less we say, the more we can find out, particularly for individuals who are at the more moderate stages of their clinical syndrome. Provide those multiple avenues for communication. So that is that adaptive nature of figuring out, does someone communicate or provide responses reliably when I let them change how they communicate? Help a person to communicate when asked. So not everyone wants to be interrupted. Not everyone wants to finish you to finish their sentences or to provide options. But sometimes that is exactly what you need to do to be a responsive provider. And that can take a little bit of trial and error, but it all depends on building that relationship with your patient. Part of that is also acknowledging frustrations. Sometimes it's just helpful to acknowledge that someone is experiencing a communication breakdown. Speaking clearly and slowly, in addition to saying less at a time, can also be helpful. That doesn't mean speaking louder, but just being mindful of the choices that you make when you say something. You can provide choices sometimes when you are trying to figure out a certain piece of information. So you can provide a forced option. So instead of an open-ended question saying, what's your favorite food? You could say, do you prefer A or B? Provide time to process and answer. And this is where that comfort with silence can play a huge role. We tend to need more time to formulate an idea and to even process what someone has said to us when we do experience a dementia. And so whether that is communication-based, whether that's memory or executive function-based, it just might need more time. And providing that time can reveal that. Sometimes in our own discomfort with that silence, we move on too quickly or try to fill in the blanks. And that isn't always the best way to determine what someone's actual capability is in that moment. Do clarify when needed. So if you notice that you're not quite understanding what someone is communicating, recast it. And what I mean by recast is repeat back to them what you understood to be true, or what you understood them seemingly to communicate. And then finally, that immediately ties in with this last point: do not make assumptions about what the patient can or cannot do, or can or cannot communicate. It sometimes just takes that clever adaptation to your communication style. So in terms of the environment, there are many things we can do to enhance success. So when possible, reduce background noise. If you are in a room where the patient's window is open and there is rush hour traffic, and then you have the door open and there are people talking in the hall, that only isn't a distraction for you, but also for the patient. So they are taking in all of those stimuli while also trying to attend to you, and that can really confound their performance. You want to limit visual distractions. So if you are ruffling papers or you are checking things as they are coming in around you, you have plenty of things scattered around, that can also result in a distraction and reduced attention. You want to face the patient, especially these days where we want to document as well and as precisely and as quickly as possible. It's easy to disengage by looking at the screen that's at the side and to forget to look at the patient. And not only is that a noise and visual-based distraction, just reduces that engagement with the person and reduces lip reading ability. You want to limit technical jargon. So when it comes to talking about some of these things, I would never ask a patient, how's your grammar? But instead, I would ask them, tell me about a typical Sunday, and then see for myself what their grammar performance is. Augmenting your communication. So again, this might include speaking in a different way. That might mean different modes of communication, using visuals, providing whiteboard options for more free flow, creative responses, whatever works to enhance the functional success of this conversation. And then finally, as with anything, you want to involve care partners and family members, not only to see the reliability of the patient's responses, but to get a fuller picture of what their communication concerns may look like outside of your interaction. I have additional resources listed here that are specific to progressive changes in communication. So the National Aphasia Association has an excellent resource page on language-led dementia syndromes. We, of course, have the American Speech, Language, and Hearing Association that speaks to comprehensive dementia care and the speech-language pathologist role. We also have the newly formed International PPA-SLTP network, which is an international group of speech-language pathologists or therapists around the world working to enhance the care of people living with those primary progressive aphasias. And then finally, we have the Academy of Neurologic Communication Disorders and Sciences, which also speaks to these language-based concerns that can occur on the dementia spectrum. I had many references supporting this work. So there's a QR code there for you to scan if you'd like to look at any of those publications. And then otherwise, I think I'm ready for questions.
Great. Thanks, Dr. Gallée. I actually appreciate you putting the QR code for the references up. I haven't really seen that before, but it's a nice, easy way to capture those. I do have some questions that have already come in, and I thought I'd pose those.
Sure.
So Eveline said, what about an elderly individual for whom English is a second language, but they were able to speak English well with good grammar and word usage? But now switches between the languages or even speaks their first language to only English speakers without being aware of this. Is it likely that they are also not understanding what is said to them?
That is such an excellent question and so representative of what I think really falls through the cracks in many clinical care settings. We have so many multilingual speakers in our country, and the fact that everything is still often based on monolingual speakers, particularly monolingual speakers of English, is just a huge disservice. I would say the change is something that should definitely be a red flag, as you're noting. If someone was a non-native speaker but was performing very, very well or operating really well in their non-native language beforehand, and that goes away, then that is an indication that there needs to be follow-up assessment. And that is something that a multilingual translator of those languages can then do really nicely. There are certain assessment protocols being developed, and that should be then completed with a translator and a speech-language pathologist in tandem. It's really hard to establish otherwise what the source of the change is.
And I would assume hard to establish whether they're understanding in the languages that they used to speak. Is that right?
Absolutely, yes.
Cheryl used to have a client who would lose her breath while speaking. She would be talking and end up losing the last part of a couple of words while talking. Do you have any thoughts about that and what might be behind it and how maybe to address it?
Yeah, so that is also something that I would immediately indicate being a concern. So if breath support is going, that's indicating that in some rare cases, it's coordination of breath and remembering to breathe at the right moments, but it usually is a change in strength. And that's where we do become concerned. Like I said, it's relatively rare that it really is just someone forgetting to swallow or breathe, but instead is an indication that something about the function isn't there anymore or it's going away. So you can work together with a respiratory therapist as well to assess some of these concerns, and then also see if they are self-reporting a difference based on time of day. Does it increase when they're at the end of the day and they've used their body much more than right at the beginning? Does it change when they're laying down versus when they're standing or walking? That can also be helpful.
Interesting. Another attendee said on older adults with diverse backgrounds, do we have any demographically adjusted metrics to improve cognitive or language screening? For example, bilingual patients, patients without a high school education, cultural norms such as partner dynamic communications?
That is such a great question. No, but they're being created, is what I can say. So people are working very, very hard at multiple institutions across the US to actually have responsive and representative norms. I've gone on this spiel many times in my short career at this point, but very many of our assessments that we use today were created in the 70s and 80s based on a very small population of white, highly educated gentlemen in the Boston area. And that in of itself is so specific already that it's hard to see how that would generalize to our wonderful and much more diverse population. So it's happening. It will take a while before it's implemented in patient care. So that's where careful collaboration with culturally responsive and also just generally knowledgeable healthcare providers is really essential, and figuring out and establishing nice community relationships and liaisons there can also be of benefit.
Have you had this is me coming up with the question, but
Yeah.
have you had the experience where you've had interpreters in the room, and are interpreters able to convey to you information about language difficulties that they're picking up with the patient?
That's a really good question. It is a hot topic in the speech pathology world. And part of the reason is that interpreters, in a wonderful way, are really focused on functionally communicating what someone has said. But as the SLP, I don't always want to know the successful version of what they said. I want to know the errors. And so instead of what sometimes happens with an interpreter, they may not share all the errors that are happening, right? Or they may fill in the blanks or adjust for certain sound errors that I might not be aware of because I don't speak the language. So that's where it does take interpreters who have that training and awareness to know, ooh, I should give word for word error types. So I might really care that someone said a voiceless sound versus a voice sound, because one takes more musculature to produce. And if they're always changing all of the voice sounds to voiceless, then that's an indication that this person is experiencing difficulty in making that type of sound.
Interesting.
Yeah.
So Robin said that she's had two patients with advanced Alzheimer's who wanted to chew or bite on something. Do you have a sense of what that indicates and what's the best intervention?
Yeah, that can be attributed to oral fixation and just increased oral habits that we do see at the more severe stages of Alzheimer's. So if one concern there is safety as well, whether that comes down to if someone's eating all the time, they might not be safe eaters. And so they might be at more swallow risk or swallow concerns there. They also might chew or accidentally bite themselves in that process. So my approach generally has been to lead into it by finding certain bite sticks that are safe, or like a cinnamon stick even, or the equivalent of something like that, where they can lean into the desire without having a safety concern.
Interesting. And Linda is asking, can you comment on BIG as an approach to increase volume and breast support for dementia patients?
That's a great question. So I'm not personally trained in BIG, but what I will say is that there is that trade-off with these progressive syndromes of teaching new things. So We want to really think about strategies that feel very natural and to introduce them as early as possible before something becomes a concern so that it has time to become a habit. So when it comes to implementing an approach, implementing it as early as possible, just like we would implement compensatory strategies before something is necessary. We do see success in implementing elements of certain volume amplification techniques. So I can speak to LSVT loud that's been used in Parkinson's. That is a really great technique to enhance vocal volume and loudness and intelligibility because of that. And it turns out some follow-up studies have shown that even telling someone speak louder or articulate more can make someone more intelligible. And that sounds so simple and almost condescending, but it actually can be really good feedback also for patients who may not remember to use certain strategies. So,
Well, you bring up, so I'm going to ask another question
yeah.
just from my own experience. You brought up Parkinson's, and there's a lot of issues with language and speaking with patients with Parkinson's. How is the screening approach and the intervention approach different, or maybe it's the same for patients with dementia versus patients with Parkinson's language speech issues?
That's a great question. So, in terms of what the patient might be experiencing in the assessment, it might be relatively similar. Um, in that I will ask them to talk about certain things. I'll ask them to talk about a typical weekend, something that I already know from their medical history or their occupational history. For the Parkinson's patient, I will be listening to overall intelligibility and stamina and success. Whereas for the more stereotypical memory-based dementia, I will be listening to content. And I will care less about certain speech sound errors and production because they tend to be more inconsistent in the latter population.
Okay, I don't see any other questions, so I just can't tell you, and I've seen comments, how much we appreciate the sort of pragmatic approach that you've offered to speech therapy and the considerations, and also just some help with thinking about interventions, and particularly for me, how to communicate with a speech therapist about what's going on so that the best assessment and intervention can occur. Thank you so much.
My goodness, my pleasure. I'm so glad.
Yeah, you can see a little hand clapping.
Yeah.
All right, everyone, thank you. I will see you next week. And thanks again to Dr. Gallée for a great talk. And have a wonderful weekend.
Thank you so much, everyone.